So what I'd like to do in our remaining time together is bring up the dream team of presenters so we can each have a few. We have about 150 questions. We're not going to keep it. We're going to each take one and put the rest on the website, and then just do a few closing observations. So can Michael, don't be shy. Can we just have you guys come up here real quick? And I'll kick off with a couple, just two questions to me. One question was 15% of the Norwegian adolescents dropped out of the study, which begs the question, when does and how does DBT fail? And that's why we do randomized trials with long-term follow-up so that we can actually try to see in comparison conditions, what are some of the factors, the individual factors, what are some of the family factors, what are some of the diagnostic issues. So we don't know the answer to who these kids are yet, but hopefully with the follow-up research we'll be able to answer that. And one other question to me was, could I please explain or describe how teenagers can access me for telephone coaching? So, very simply, this is I know it looks like a dinosaur, but most people haven't seen these in years. This is called a pager. My teenage patients are horrified. They don't know what that is. But so anyway, I have to teach them how to do it. And I tell them that I am available 24/7. The thing is, they also know that I teach at conferences such as this, elsewhere, and I see other clients, and I'm not going to interrupt my teaching lesson or my other clinical services to address the call. So they have to understand there may be up to a 2-hour window usually. You know how we have our coffee breaks every 2 hours? That's the time. So usually it's within a 2-hour window that that's within my personal limits that I'll then be able to get back in touch with them and try to do some coaching as I can. But every DBT therapist has their own limits to that effect. All right, so wow, this is impressive. This is an impressive showing. So, ladies, who do we have next?
Okay, let's just do it in order. So,
Yeah.
Mary, do you want to go up?
Sure.
Just repeat your question.
Somebody wants to know what the role of ADHD is in behavioral emotional disorders in adolescents, that is BPD. Some kids with BPD have attention deficit disorder. More are diagnosed with it than have it, and more are medicated for it, practically than are diagnosed for it. So obviously some kids do have it, but it's not been a problem that we've noticed in large numbers.
This question to the Costellos, sounds like a rock group. Gentle, easy manner, Alan Frazzetti training, more on what this entails. Well, it's in the Family Connections training. It says you have to find your own level of gentle. And it's one of those things that's kind of elusive, like mindfulness. And I remember when we were trained by Alec and Adam, they spent a lot of time on it, getting your own level of gentleness, easy, as opposed to the sky is falling and running. And so it helped. The more we thought about it, the more we taught it, the more we got into it. It's finding a way to keep yourself, the middle path, find yourself at a nice level and easy pace.
This is, did we notice any behavioral symptoms in Christopher in childhood, or was it a sudden change? Well, I started out with the slides. He was a screamer. He cried and cried. And I spoke to my OBGYN, and she said, I've had a lot of babies scream at birth, and they don't have borderline. Of course, she may not know that one way or the other. But he was very hypersensitive as a very small child. He was hypersensitive to smells in the car, to smells in the house, to temperature. He was very hypersensitive. And I would say the change from being hypersensitive to being angry was fairly quick. And I would say that was puberty kind of pushed in, and that got everything going. So he was about 15 or 16 when that turned around.
My question is, would PTSD include extreme emotional pain caused as a result of interpersonal losses due to BPD behaviors? For example, extreme avoidance, being unable to revisit places I was in with my ex-boyfriend. And the general answer to that would be yes, that could be included. Post-traumatic stress disorder is any conglomeration of avoidance and re-experiencing and arousal symptoms. To have formal PTSD, again, you need a certain number in each of those groups, but lots of people have a trauma, and it can be as a result of what someone here is calling BPD behaviors, in which a situation was created in which there was extreme hopelessness, terror, fear, and in which someone felt that their lives were going to change forever after that moment. And those things can reach the height of something being traumatic. And PTSD is that pattern of behaviors that follows that. And one of the biggest ones is avoidance. So if someone has a significant loss in their life and they feel hopeless or terrified by that loss, and it's very significant to them, and then they notice this pattern of behaviors, unable to revisit extreme avoidance, those are the very kind of behaviors that we're talking about, and they are maintained because to approach those places or those things are very difficult for the person, cause extreme anxiety, and these avoidance behaviors are then reinforced by escaping potentially very distressful situations and get maintained. So a lot of the same interventions in terms of stress hierarchies and approaching behaviors gradually and reinforcing them with DBT skills can be used for things like this that sound like not the traditional traumas we hear about. I hope that's helpful.
All right. Question. How are cultural and religious beliefs integrated or considered in multifamily therapy groups? First, John and I don't do multifamily groups. We just do parent skills groups just because of the way our program is set up. But having said that, really it's incumbent upon the therapist to know about cultural differences and to blend that into your treatment. We've treated a number of families from the Orthodox, Jewish Orthodox community, and there are certain kinds of things that you have to know about that community when you're teaching skills and trying to be helpful. In the same way that there are certain cultures where expressed emotion and privacy in a family is a highly valued kind of thing. So it's less avoidance and more something that's culturally syntonic. But this is the kind of thing that therapists really need to know when you have someone from a diverse culture. I hope that was helpful.
I would just add that I think in the group, we're teaching the skills and we have some discussion. But ultimately, what we stress is that each person, each family member needs to use the skills, find ways to use the skills in a way that will work for them. For instance, in DBT, some people use prayer as distress tolerance, and other people don't. So it's all about everybody finding what works for them and what is consistent with their values.
Hi, the question I got is, what I have learned is that my daughter will not progress unless we have family skills training too, and possibly some family sessions. What is the best way to get this across to professionals who do not have the same perspective, references, resources, etc.? So first of all, I certainly didn't mean to give the message of taking away hope from people who have their kids hooked into treatment. That doesn't include a family component. Not every program does. There might be good DBT programs that aren't necessarily including family members in treatment. We don't have data yet, as far as I know, that has compared that. I'd like to see that comparison done, actually, to compare programs with the family component versus programs with adolescents who don't bring in families, and just see the comparative, see the comparison. So, but having said that, since it made a lot of sense to us and many other people to get family members involved, I would say that one thing is to request it and ask about it directly. Another thing is to possibly look for a program that has that component. But another option is to make use of the many additional resources that are available to parents. So there's, of course, the Family Connections program that people can look up and get involved in. And there's also a number of good books out there now that parents can use for their own education to be the most supportive and helpful to their children. Like Michael Hollander's book, Helping Teens Who Cut, and Sharon Manning's recent book, I think it's called Loving Someone with BPD.
Yeah.
So those are some additional resources as well.
My question was, how are siblings involved in the outpatient family therapy DBT treatment plan? Which is a question that actually comes up quite a bit. In the multifamily skills group, unfortunately, there's just not enough room in the room to include siblings, and a fair number of families come in on the fact that siblings may feel left out. They may also need the skills. So what I would say, as far as the skills go, it depends on the family, it depends on your relationship with the individual therapy patient. But you may consider bringing in a sibling and having, for example, the patient teach the sibling the skills. You might consider having one of your colleagues meet with the sibling to give them an orientation to some of the skills. It really depends on what the sibling is looking for. You know, for example, if they meet criteria in terms of the problem areas, they may need their own DBT treatment. As far as the family therapy piece of things, that's a bit trickier because I think that I'm hesitant to just bring them on in without really understanding from the parents what the goal would be for a family therapy session, and without getting some sort of assessment of their relative skill level themselves. So I think there's definitely a place for siblings to come in. I think that the same transactions that go on between parents and teens can certainly be going on between the identified patient and their siblings. So there is a place for it, but I just want to encourage people to do assessment before they have family therapy sessions. And as I mentioned earlier, to also consider teaching validation and modeling it before you do any problem solving.
This question is DBT recommended as therapy for more than just borderline or just personality disorders? I would say yes. I would say DBT is helpful for everybody, and as Alec alluded, we want to start teaching it in kindergartens, but you know, generally speaking, right now at CBCW, especially for our adolescents, some of them do meet borderline personality disorder criteria, and we do want to be open about that. At the same time, that's certainly not a requirement. So we use the 5 problem areas as described in Alec and Jill and Marcia's book. And typically our adolescents need to meet 3 of the 5 problem areas. I know in the schools, I think you guys are doing 2 of the 5 at a minimum, right? 2 to 3. So it really depends, but while a lot of the speakers have mentioned it's really important to discuss and provide psychoeducation about the diagnosis of borderline personality disorder, we also focus on multi-problem teens and suicidal teens and don't exclude people from treatment by any means if they don't meet criteria.
Jim was the last speaker, so do we have a question for Jim, a really good one that he's going to have difficulty answering? Put him on the spot. Anything about placement or schools or anything? Yeah.
In your slide, you said there's no place like home. Could you expand upon that?
Sure. The question is about there's no place like home and sort of why that was a part of the presentation. As there's a number of consultants here as well, I'm not a huge fan of placement. It's a really disruptive, chaotic, detaching type of process. So I think if there's a way to sort of utilize community supports, if you're in a community that's going to be able to provide ample resources that it makes safe, that it's safe and effective to have a student at home and the home environment is safe for the person, I'd much rather see somebody transition home. It'd be really difficult to be in a locked setting or in a residential treatment center and then transition back out of that when you're used to having very little, if any, autonomy and sort of having every minute structured and then sort of going on to being a 16, 17, 18-year-old person that's expected to sort of be able to be self-sufficient and get from point A to point B without that much support. So obviously there are numbers of situations that we've talked about where placement is necessary because of home, because of the individual, because of a number of factors. I think if it's possible to negotiate a placement at home with a pretty intensive outpatient team and supports, I'd much rather see that.
I've got a question is, since psychotropics prescribed have little if any effect on BPD, doesn't prescribing them, for example, SSRIs and benzos, teach them that using drugs to regulate unpleasant emotions? And amen. I mean, there's no data that just for pure borderline personality disorder that medications work. And certainly, I mean, if a child has worked out that self-injury regulates their emotions, but I, as a clinician, prescribe a medication like Klonopin that regulates their emotions, I don't know exactly what the difference is between those two things, if what it does is stops curiosity and stops long-term effective change. So yes, for pure BPD, we don't prescribe medications. Many kids come in on multiple medications. Often it's because desperate parents and desperate psychiatrists and doctors have thrown medications at whatever the problem is. And we try to very, very carefully make sure that we get the diagnostic criteria right, so that because there is so much comorbidity, if someone does truly have bipolar disorder, then clearly medication is indicated. But for BPD itself, at this point, no medication. So this is it. The brain uses 20% of the caloric input that it takes in during the course of the day. And I think that today you guys have used more than that. And it's probably going to be an exhausting thing. There's so much to metabolize, so much to digest, so much to think about. But we hope that you'll go out there as compassionate people and take what you've learned with you, rethink the situation. We're going to take the show on the road, thanks to the NEA BPD and to my colleagues who've spoken today. But thanks to all the volunteers, and maybe we can open the door so we can really give out a thanks to them who sat outside and taken the discussions. We hope to go out to the West Coast sometime later in the year. So thank you all so much for coming, and have a great weekend.